start your video.
We are live.
Hello, good evening, everyone. Today we've gathered here for iFocus online lecture number 435 from the Cataract module. And we have with us today Dr. Kruthika. She's a fellow at Center for Sight and she'll be speaking on posterior capsulotomy, its indications and techniques. I would like to welcome our moderator for today's session, Dr. Piyush Bajaj, sir. He's done his MBBS from Manipal College of Medical Sciences and his DOMS from Rajiv Gandhi University, Bangalore, followed by a DNB from Venu Institute, Delhi. Sir holds a fellowship in oculoplasty and cataract from Arvind Madurai, and currently he's working as an associate consultant at Center for Sight, New Delhi. Sir has also worked as faculty with Help Me See Foundation for phacoemulsification training at Venu Eye Institute and Delhi and Rewari, both centers. He's also been a part of training program by Alcon PDP at Dr. Pawan Dheer Eye Institute and Research Center. Sir has also taken part in multiple conferences and is a part of the teaching schedules and mentoring DNB students at Center for Sight. We welcome Dr. Piyush, sir. Over to you, sir, for our chairperson's introduction.
Thank you, Kanika. I'm audible?
Yes, sir.
Hi. Thank you. Thanks for the kind introduction. I'd like to introduce Dr. Paresh Vaidya. He's a chairperson for today's session and iFocus. Sir is a senior consultant at Center for Sight, Surat. Has done his MBBS, DO, and MS from Government Medical College, Surat. Holds an experience of more than 25 years in anterior segment, cataract, and refractive, and works as a comprehensive ophthalmology in Surat. Has served as a medical director of South Gujarat Center for Sight Group of Eye Hospitals, has been a president of Surat Medical Consultant Association from 2014 to 15, president of the Rotary Club of Surat West from 2020 to 21, has performed a large number of phacos, more than 60,000 phaco cataract surgeries till now, more than 100 femtocataract surgeries, and adds on a more than 21,000 LASIK surgeries, among which more than 100 femto-bladeless LASIK surgeries and more than 200 ICL surgeries in his name. To add on to the list is more than 100 C3R surgeries, 20 smile refractive lenticle paste procedures, and 1,000 cataract, that is free cataract surgeries in his time. He has been putting more premium IOLs, torics, multifocal and trifocals now, has delivered many talks and lectures at multiple national and international conferences, has been a panelist in Bosch and Lomb sessions in Ahmedabad in 2018, has been a part of various workshops for ICL surgeries for making LASIK flaps. And by the institution, he has been awarded the Mentor Award, that is highly remarkable. That is 2 times. Has received a gold medal by at IRSI Conference Delhi 2023 by the Lok Sabha Speaker Shri Om Birla ji. Next slide. I'd like to introduce our today's speaker, Dr. Kruthika SH. She holds an MBBS from MR Medical College, Gulbarga, Karnataka. MS from JGM Medical College, Davangere, Karnataka. She is currently a fellow at Center for Sight, New Delhi. Adding to her achievement, she has authored more than 4 journal articles and delivered various presentations at national conferences. And she's a co-author on a chapter, The Three Pillars of Corneal Evaluation, Corneal Tomography, Biomechanics, and Epithelial Mapping in the AIOS Dynamic Evo. And she is a very great learner and has started as initial days of her fellowship only. She has started her doing a lot of independent FACOs now. Over to you, Kritika, now.
Thank you for the kind introduction, sir. I'll just share my screen. Is my screen visible, sir?
Yeah. Yes, Kruthika.
Good evening, everybody. Today, let's talk about posterior capsulotomy, its indications and techniques. I have no financial interest. So, what is posterior capsulotomy? As the name states, it means making an opening in posterior lens capsule deliberately. That is, intentionally making an opening in posterior lens capsule. How do we do it? Either by laser delivery system or by using a surgical instrument. It can be done in two steps. One in primary approach, one in secondary approach. In primary approach, that is concomitant with cataract surgery. Indications of which are pediatric cataract surgery along with silicone oil removal, which is anterior approach method. In case of pre-existing thick posterior capsular plaque, it can be done secondary as well, that is post-cataract surgery, where in case of management of posterior capsular opacification. So starting with the one of the approach, which is primary posterior capsulotomy. As told before, it is performed concomitantly with cataract surgery. Indications, as discussed before, are the ones like pediatric cataract surgery, along with transpupillary silicone oil removal, that is anterior approach method, and in case of pre-existing thick posterior capsular plaque. A quick detail about pediatric cataract surgery. It is the most common and important complication after pediatric cataract surgery is posterior capsular opacification, the rate of which being it can reach up to 100% in children less than 4 years when the posterior capsule is left intact. Hence, the outcome of this pediatric cataract surgery depends on how we manage posterior capsule. That is, we have to do primary posterior capsulotomy and vitrectomy, especially in younger children, as the onset of PCO is faster in them, which leads to amblyopia. Capsulotomy here can also be performed secondary to pediatric cataract surgery using laser delivery system. When to perform the posterior capsulotomy comes our next question. In children less than 8 years of age, in case of children having nystagmus, in case of uncooperative children for YAG laser capsulotomy, that is in cases like kids with autism, kids having ADHD and all. And it can also be done in case where there is presence of posterior capsule plaque pre-existing or there is PC defect present. The procedure involved in making primary posterior capsulotomy can be the technique is which can be done either manually or by using a vitrector. Manually, which is called as capsulorhexis, same like anterior capsulorhexis, and vitrector using a vitrector, which is called as vitrectorhexis. To note here, vitrectorhexis is predictable, gives a predictable and reproducible outcome with a short learning curve and less surgical time. Route of approach of posterior capsulotomy can be either limbal or pars plana route. Limbal is called as anterior segment approach, and pars plana or plicator route is called as posterior segment approach. Coming to anterior segment approach, it can be done after thorough removal of all lens materials. The capsular bag is adequately filled with high viscosity sodium hyaluronate viscoelastic substance, after which a circular posterior capsular tear is accomplished, followed by anterior vitrectomy in cases needed. It can be performed either before or after IOL insertion. And the target we aim for in case of anterior segment approach is a well-centered posterior capsular axis, concentric to and smaller than the anterior capsular axis. There is a disadvantage for this as well, and that is it can leave residual vitreous in the anterior chamber oftenly. And also, if we want to implant an IOL into a small, soft, vitrectomized eye after an anterior approach posterior capsulotomy, it represents a much greater risk of IOL dislocation into the posterior vitreous space. This is a surgical video showing posterior capsulotomy. The surgery performed by one of our senior consultant at Center for Sight Eye Hospital, Dr. Sumit Monga sir. So as we can see here, after aspiration of all the lens material, what sir has done is he has given a neck on the posterior capsule with a capsulotomy, after which the capsule is held with a forceps and a controlled tractional movement of the capsule is being done here to complete a capsulorhexis. As we can see here, a well-centered, smaller size of posterior capsulorhexis is being performed, after which We can even inject the viscoelastic substance in the burger space, following which anterior vitrectomy is being performed. And capsular bag is inflated adequately with viscoelastic substance, and then IOL is placed in the bag. This is another surgical video performed by Dr. Sumit Mongasar again. Here, after placement of IOL, that the previous one was before placement of IOL. This one is after placement of IOL. So after placement of IOL in the capsular bag, we use a vitrectomy probe to make posterior capsular excess and anterior vitrectomy. This is another surgical video performed by Dr. Sumit Mongasar again, in which before implantation of IOL, we can see that with the help of vitrector probe, there is sir is making capsular excess. We could also see in this video that the edges of the posterior capsular excess was called in case of using vitrectomy probe. Coming to the next approach, which is posterior segment approach. As told before, it can be done either by pars plana route or pars placata route. In this procedure, with irrigation cannula placed in the anterior chamber, a microvitreoretinal blade is used to enter the pars plana or placata posterior to the limbus. We should make sure here the incision that is given posterior to the limbus, in case if the child is less than 1 year of age, that incision has to be 2 mm away from the limbus. If the age is 1 to 4 years, incision should be 2.5 mm posterior to limbus. If the kid is more than 4 years old, then the incision should be 3 mm or more. After which the vitrector is inserted through this opening. That is the opening made by MVR blade, and to open the center of capsule, followed by anterior vitrectomy. Alternative methods to make the posterior capsular excess instead of vitrector are the ones like fugoplasma blade and radiofrequency diathermy. Posterior capsulotomy and anterior vitrectomy are commonly carried out after implantation of IOL. When we go through posterior segment approach. Advantage of this technique is that there is chance of an anterior, the chance of an anterior wick of vitreous tracking to the corneal wound or any ports is eliminated in this technique, because we are doing it posterior approach after placement of IOL. And the disadvantage of this technique is there is risk of subretinal infusion, there is risk of vitreous hemorrhage, and there is risk of sympathetic ophthalmia. Why? Because we are touching the uveal tract while doing the pars plana route approach. This is a surgical video that I've taken from YouTube, in which we can see the posterior segment approach. So after suturing the main wound, what the surgeon is doing here is nick is being placed on the posterior capsule by using the vitrector by using the capsulotomy behind the IOL. After which MVR was inserted and trocar was placed and vitrector was inserted. After which posterior capsular excess was accomplished and anterior vitrectomy completed. Now let's discuss about what the size of posterior capsule opening should be. It should be large enough to help avoid visual axis obscuration, but small enough that sufficient peripheral capsular support remains for capsular fixation of an IOL. That is for optic capture. Ideally, the surgeon achieves a central circular opening in the posterior capsule about 1.5 to 2 mm smaller than the IOL optic, around 4 mm. So there is one more technique, which is femtolaser assisted posterior capsulotomy. It is a feasible but requires redocking after lens aspiration. The procedure done here is after we finish the cataract surgery, just before implantation of IOL, we either suture the pores or we do adequate hydration of the pores and do sterile docking of eye again on the femto machine. After which a 3-dimensional OCT scanning of the posterior capsule and treatment with femtolaser is done. Following undocking, we shift back the patient again to the operating table and use forceps to remove the posterior capsular disc that was created using a femtolaser assisted surgery. Advantage of this technique is it gives a precisely centered, circular, continuous anterior and posterior capsulotomies that can be aligned with each other. So to note here, we can also use femtolaser-assisted posterior capsulotomy. There are case reports which was published in recently, and it can also be used in cases of capsular blockade syndrome as well. So the next indication of primary capsulotomy is cataract surgery in eyes filled with silicone oil. It can be performed in silicone oil filled eyes, planned for cataract surgery and silicone oil removal concurrently. Also, this procedure is preferred in eyes undergoing cataract surgery with silicone oil removal with a pre-existing PC plaque as well, to avoid doing a posterior yak cap. The procedure followed here is, after doing a routine cataract extraction in which aspiration of lenticular material is done, we do a posterior capsulotomy either by a manual, that is capsulorhexis, or using a retractor, after which an infusion cannula is placed at the capsulotomy opening from one end, that is from one port, to remove the silicone oil passively from posterior segment. And here, what we should make sure is, from the main port, we should use a cannula and depress the scleral lip so that the silicone oil comes en masse from the posterior segment to the anterior segment and it is aspirated out of eye. This is a surgery done by Dr. Bharatratna sir, a senior consultant at Center for Sight Eye Hospital. This is a patient who is undergoing cataract surgery in silicone-filled eye. Silicone oil was placed in this patient because for retinal detachment surgery. So once retina was stable, patient was planned for cataract surgery and along with the removal of silicone oil. So as we can see in this case, routine phacoemulsification is being done. So after completion of routine phacoemulsification and cortical matter aspiration, surgeon makes a posterior nick, that is a nick on the posterior capsule, following which posterior capsulotomy is completed by using a forceps. Again here, a gentle tractional force is given circumferentially. So following which, after completion of the posterior capsulorhexis using a forceps, in this case, what surgeon does is, from the left port, as we can see, he has used a irrigation cannula to remove the silicone oil, and from the main port, sir has used a cannula to depress the scleral lip, because of which all the silicone oil comes en masse, as we could see, after which the IOL was placed. Advantages of this technique is, there is a clear corneal incision made, anterior approach is faster, it is safer, and offers rapid visual recovery. It is less invasive, hence reduces the risk of subretinal infusion, vitreous hemorrhage, sympathetic ophthalmia, which was spoken about in case of posterior segment approach by pars plana route. It also reduces the need for NDR capsulotomy postoperatively. Drawback for this technique is, there is violation of PC integrity, theoretically increasing the risk of capsular bag instability, postoperative retinal detachment, and cystoid macular edema. And also, since the silicone oil is coming back to anterior chamber and is drawn out of the eye from the anterior chamber route, there is risk of damage to corneal endothelium as well. So once the primary approach of our techniques is done, let's discuss about the secondary approach, whose most common indication is posterior capsular opacification. Posterior capsular opacification is the most common postoperative complication of cataract surgery, incidence of which is 20 to 50% within 2 to 5 years post-cataract surgery. Here, why posterior capsular opacification happens is, there is proliferation, migration, and differentiation of lens epithelial cells along the posterior capsule to opacify the capsule. There are two types of posterior capsular opacification, one of which is fibrous posterior capsular opacification, and the second one is pearl posterior capsular opacification. Fibrous, also known as membranous, why it occurs? It occurs as a result of limbal epithelial cells lining the anterior capsule, which undergo epithelial mesenchymal transformation and migrate along the posterior capsule. This presents as wrinkles and folds on posterior capsule. The second type, which is pearl PCO, which is called as proliferative. The name itself says here, the proliferative. It is caused by proliferation of pre-equatorial lens epithelial cells in an attempt to rejuvenate lens fibers. In this case, this type of pearl PCO presents as either L-shaped pearl, which is very much clearly evident on retroillumination, or shimmering rings pattern. Management of posterior capsular opacification most commonly is conventionally is by using a laser. Rarely it is done by surgical capsulotomy. Indications for this type of capsulotomy in a case of posterior capsular opacification are in case of decreased visual acuity, contrast sensitivity, glare, diplopia, or difficulty in examining posterior segment of eye. What is used in case of posterior capsulotomy? To treat the posterior capsular opacification, as all of us know, the most commonly used Nd:YAG laser machine. What is it? It's a relatively non-invasive, safe, and effective technique. We use Nd:YAG laser here. That is, Nd:YAG stands for neodymium yttrium aluminum garnet laser. What is this Nd:YAG? It's a lasing medium. It's a synthetic crystalline medium. So this is a standard treatment of approach for management of PCO in adults or older children. It uses a quick pulsed Nd:YAG laser to apply a series of focal ablations in posterior capsule and create a small opening in the visual axis. Nd:YAG laser, as told before, the full form. The laser medium is made up of synthetic crystalline material, that is yttrium aluminum garnet, which is doped with a chemical element which is neodymium. Light energy source used in this laser is flash tube or laser diodes. The latest ones use laser diodes. Wavelength of this Nd:YAG laser is 1064 nanometer. How it acts is the laser pulse and dual spot aiming beam can disrupt ocular tissues by achieving optical breakdown with a short high power pulse. There is a mechanism for this as well, and it is when infrared light of 1064 nanometer is exposed to ocular tissue, it causes ionization and plasma formation in the ocular tissue. This plasma formation releases acoustic and shock waves that disrupts the ocular tissue, that is the posterior capsule in this case of opacification. The technique and patient preparation for this technique is, after doing the prior detailed ophthalmic history and evaluation, explain the nature of procedure and obtain an informed consent from patient and attendants. Pupillary dilation is optional according to doctor. And the positioning here is, it is performed at a slit lamp equipped with a YAG laser while the patient is in a seated position. It is performed under topical anesthesia. It can also be done without anesthesia as well. Here we can use an equipment. We can or cannot. It is left to doctor again. One of equipment that can be used here is a lens, which is Abraham YAG capsulotomy lens in conjunction with a coupling agent, which is 2% HPMC, a viscoelastic substance, to form a seal on the eye. What this the capsulotomy lens, that is Abraham YAG capsulotomy lens, does is it magnifies the image almost to 2 times. Advantage of this is, one, it keeps the eye open and helps in stabilization. The lens has a 10 millimeter helion neon YAG coated plano-convex lens, which as told before, gives a 2 times of magnification. Rightly, 1.8 times magnification button positioned at the center. This focuses the beam spot size exactly on the posterior capsule. This also increases the convergence angle to 24 degrees from 16 degrees. It decreases the area of laser at the posterior capsule to 14 micrometer from 21 micrometer. Energy used in case of Nd:YAG laser depends upon density of posterior capsular opacification. Typically, a minimum of 1 to 2 millijoule is started with, after which we can titrate the energy based on how the posterior capsule is responding to the shots. We should make sure, what we should remember here is, in case of posterior capsular opacification, when we use Nd:YAG laser with higher energy levels increase the intraocular pressure and inflammation. And posterior capsule is examined for wrinkles. How this is done is, posterior capsule is examined for wrinkles that indicate tension lines. We should short the YAG laser on these tension lines to increase the opening size. The shots placed result in largest opening purpose when it is placed on the tension lines. There are a few patterns of capsular openings. One of the primary of them are, one is cruciate or cross pattern, and one more is circular or can opener method. The second one here is a modification of cruciate or cross pattern. What is cruciate or cross pattern? In this, what we do is we start giving shots of Nd:YAG laser from 12 o'clock to 6 o'clock. after which we give laser shots from horizontally at 3 o'clock towards 3 o'clock and 9 o'clock position. This leaves a rhomboid-shaped posterior capsular opening. The disadvantage of this technique is as laser shots are placed along the optical axis, if in case there is IOL pitting, that will cause glare. So modification of this pattern of cruciate approach was done, that is Christmas tree pattern, wherein optical axis route was avoided. How it was done is from 12 o'clock, just give shots, one at 5 o'clock, one towards 7 o'clock. And the base here falls back attached to the posterior capsule into the posterior segment. So it keeps adherent. The problem with this is it causes floaters. Another method, that is a secondary approach, which is circular or can opener method. What is done here is shots are placed in a circular manner like this through and through, after which the posterior capsular opening is accomplished. What happens here is once the shots are placed, this posterior capsular disc falls onto the posterior segment. So there is higher chance of floaters in this case. So there is a modification of this technique as well. Just like Christmas tree pattern, what they have done in circular or can opener method is they give shots on almost all quadrants of the circle except inferiorly so that it falls back on the posterior capsule, being adherent to the capsule again, just like Christmas tree pattern. So the size of capsulotomy in case of Nd:YAG laser should be as large as pupil in isotopic conditions to avoid glare from the exposed capsulotomy edge. A small opening might be preferred for a patient at high risk of retinal detachment. Capsulotomies may spontaneously enlarge post-procedure, that is post-YAG procedure, by a mean area of 32% within 6 weeks. Why? Because of the contractile properties of myofibroblastic lens epithelial cells, IOL haptics, or both of them, which causes the alteration in capsulotomy size. How do we manage post the procedure of YAG capsulotomy? Is we can give aproclonidine or brimonidine or beta blockers, that is anti-glaucoma, topical anti-glaucoma medications immediately following procedure. Optionals are either we can give cycloplegics, or we can give topical steroids, or we can give topical anti-inflammatory agents. These medications are given for a week, and patient has to be followed up in 1 week to check for intraocular pressure spike. Usually intraocular pressure is peaks at around 1 day, that is 24 hours, and then goes on decreasing. By 1 week, it comes back to normal. So in case of high-risk cases, we should make sure, that is high-risk cases like glaucoma, we should make sure we should make the patient wait for a while in OPD, around 2 to 3 hours, check the intraocular pressure, and then send back the patient with medications based on intraocular pressure. There are a few complications with this procedure as well, like it causes elevation of IOP, it causes IOL pitting, it can cause systemic cystoid macular edema, it can cause retinal detachment, or it can also cause iritis, uveitis, or IOL dislocation itself. Elevation of IOP being the most common complication can occur of around more than 10 mm Hg can increase in 15 to 67% of eyes. Elevation of IOP, as told before, is transient. Why it occurs? It occurs because of reduced aqueous humor outflow, because of deposition of capsular debris or inflammatory cells or vitreous in trabecular mesh-work, or it can also occur because of shock wave damage to trabecular mesh-work caused by YAG laser. Second complication being IOL pitting, which we are all scared of, which I am scared of, occurs in 15 to 33% of eyes. The threshold of IOL damage here is acrylic lenses are having a higher threshold than PMMA than silicon. That is, in case of silicon IOL, the risk of IOL pitting is much faster compared to acrylic IOL. How to prevent IOL pitting is by using a defocusing technique. That is, this laser beam spot is focused more towards the anterior vitreous face than at optical interface here. And here, what happens is, because we are facing it in the, we are focusing it in the anterior vitreous face, the energy used here is usually higher than that used in the optical interface. So after focusing on the anterior vitreous face, when we place the shot, shock waves travel forwards toward the posterior capsule and disrupt the tissue. This technique also traumatizes the vitreous, so it is reserved for cases in which IOL marks are occurring with focus directly on the capsule. To note, in aphakic eyes, deliberately we should make sure to focus anterior to the capsule for opening the posterior capsule so that anterior hyaloid remains untouched and intact. Third complication being cystoid macular edema. CME develops in 0.55 to 2.5% of eyes following NDR laser posterior capsulotomy. This is considered as a protective barrier between anterior segment and posterior segment. Why it occurs? Because of movement of vitreous cavity and vitreous damage results in release of inflammatory mediators. So here, what we should remember is that in case of an eye having active CME, we should defer doing a NDR laser. This may occur between 3 weeks to 11 months after the capsulotomy. So, like I told before, in cases where there is active CME along with posterior capsular opacification, what we should do is we should of course defer doing NDR capsulotomy. But in cases where patient is having significant qualitative visual loss, then we should definitely offer NDR laser capsulotomy. Few contraindications with this procedure is absolute contraindications like media haze, that is corneal scar, corneal irregularity, corneal edema, or inability to fixate adequately. Relative contraindications like in an IOL made up of glass material because there is risk of fracture of the glass material in case of active or suspected CME, in case of active intraocular inflammation, in cases of high risk for retinal detachment. Take-home message from this topic is posterior capsulotomy along with anterior vitrectomy has to be done in pediatric age group to prevent posterior capsular opacification. Size of posterior capsulotomy should be 1.5 to 2 mm smaller than diameter of IOL optic. It's around 4 mm as told before. NDR capsulotomy is the preferred treatment for PCO in a cooperative patient. And in case of silicone oil filled eyes post VR surgery, concomitant cataract surgery with silicone oil removal can be done via anterior segment approach in selected cases. Here, the word selected cases means in cases where the silicone oil is unemulsified. In case of unemulsified, in case where there is emulsification of silicone oil already happening, we should always go via posterior approach because removal of all the silicone oil material from eye in case of emulsification is not possible usually if we do a anterior approach technique in such cases. Thank you.
Thank you, Kruthika. Very nice presentation.
Thank you, sir.
You have almost covered a lot of things. And the last point I wanted to add about the emulsification part, you had already told. What is the, like, I just wanted to ask you, like, what do you consider the best approach for a posterior capsulotomy in pediatrics, going through the anterior approach or the posterior one, or before the IOL or after, which one will be the safer one?
Sir, if we are coming to the approach first, if we are doing the limbal approach, usually the limbal approach is what is preferred, sir. If we are doing before IOL, if we are doing, if we are doing the surgery, that is posterior capsulotomy, before IOL implantation, then limbal approach is preferred. If we are doing it after IOL implantation, then the pars plana route or posterior capsulotomy, that is a posterior approach is preferred, sir. So this is when we talk about the approach. And when we talk about whether it should be done before IOL implantation or after IOL implantation, then that is... Hello?
Yes, Dr. Kruthika, after IOL implantation, is it much easier when you are approaching from the anterior side or from the posterior side?
Posterior side, sir.
Yeah. Yeah. I just want to add one point, Dr. Kruthika, that
Yes,
whenever a patient comes for a yak capsulotomy, then I think so size of a pupil and eccentricity of the pupil, it should be considered. Because sometimes what happens that the pupil is eccentric, and when the patient comes directly to you, with a dilatation of a pupil, you will not come to know where there is a center of a pupil. So sometimes you have to observe that if the eccentric pupil is there, then your shots of a laser or your capsulotomy opening, it should be sufficient enough to come in that part of a pupil. Because sometimes if you do a central round opening and the pupil is eccentric, then that may not cover your pupil area.
Okay, sir.
So what is an ideal size in a yak capsulotomy that you consider? Like in few cases, like diabetic retinopathy cases, I have done a smaller capsular access, but the retina people send it back to us saying that we at least keep it on a larger side. We have to see the fundus, we have to do the laser later on. So what is an ideal size that we should keep in mind?
So usually what is followed is lesser than the 1 to 2 mm, lesser than the size of IOL optic. But since retina people have to visualize the posterior, the peripheral part of retina properly, what they want is a bigger size of capsulotomy opening, sir. So I think a smaller, that is around 4 mm of capsulotomy size is what we should aim for, keeping in mind about the safety of IOL placement.
As you were telling that it should cover 1 millimeter in optic size, and that what you discussed actually.
Okay.
Right.
So any changes like if in a multifocal lens, should we keep something in mind for a multifocal lens while doing a yak capsulotomy? Like we have few old multifocal lenses which are developing PCO nowadays.
Dr. Piyush sir, could you please switch on your video?
Sure.
Yeah, I think so. In a cases of a multifocal, when PCO develops, I think first and foremost thing is you should first of all start with a lower energy, because sometimes if you are starting in a center and then if there is a pitting of a lens with a higher energy, if some defocusing is going on or then there will be a problem for a visual this recovery in cases of this multifocals. Especially, so I usually do start with this energy of a 0.7 or a 0.8. Then if it is not sufficient, then I gradually increases the energy, maybe around 1 or 1.1 or so. Depends upon the how the capsule is. If it is a fibrous one, or does it is a Elschnick's pulse or like that. If Elschnick's pulse are there, then they will get opened by lower energy also. But if it is a fibrous one, then you have to increase the energy.
Dr. Paresh sir, could we please see you on the video platform as well? Your video is off. Yes.
Yeah, sure.
One thing that I would like to ask from Dr. Piyush sir and Dr. Paresh sir both, in
Yeah.
your practice, sir, how many cases have you seen CME developing? I mean, after yak capsulotomy, aggravation or development of a cystoid macular edema, what is your take on this? Is it very common, or is there any predisposing factor that has to be considered?
Uh, yes, sir. Yes, sir.
How many cases of
So,
CM?
so your voice is not audible.
Means how many number of cases or how many percentage of cases develop the CME in cases of a posterior capsulotomy, and is there any predisposing factors? So I think so mainly what we are first of all focusing is on that part, that there should not be active inflammation in the eye. Also the cases, those who have a chronic uveitis or multiple attacks of uveitis, especially maybe anti-uveitis, then that all cases should be treated first for the uveitis and inflammatory conditions, and then they can be taken for the yak capsulotomy. especially in cases where a lot of patients, they have uncontrolled diabetes, and they may develop a diabetic macular edema if sometimes that capsulotomy is done in these cases. But especially I take a very utmost care in the cases where there is a high myopia, especially. So those who are having a high pathological myopias, I always consult a retina surgeon before doing a yak capsulotomy. Although I see that the fundus is clear and everything is fine, but I do take that response from the doctor via surgeon that yes, it is okay, so that we can prevent a retinal detachment. Is there any special thing, Dr. Piyush?
So the high myopia point and so initial days of my when during post graduation when we were doing yak capsulotomy, like we used to run after that small flap and disrupt the anterior hyaloid phase. In those times, I have seen 2-3 of my cases developing CME. So nowadays, even if the flap has gone back, I usually don't touch it. I let it fall down in 1 or 2 days. Patient might complain of floaters. I just tell the patient like the floaters and complaint might be there, but we should not be running into the anterior hyaloid phase and give shots over there. So those are the areas which I feel can cause us development of CME.
True, true. Right.
Sir, one more thing I would like to ask. Do you also include a OCT macula right before the yak capsulotomy? Do you think it is mandatory to first assess the microscopic structure of the fovea before performing a yak, or does it only have legal implications, sir?
Nowadays, in my practice, I have started adding OCT macula. In Delhi, we have started adding OCT macula. Definitely, legal implications are there. But yes, in all diabetics, I usually go for OCT macula, all diabetic patients. And like if the PCO is quite dense and we actually cannot have a look at the macula and we are not very sure of it, I usually write for an OCT.
That's it. Because when the dense PCO is there, it will be very difficult to evaluate the macula also. And sometimes there may be some retinal pathology or macular pathology is there. And if we assure to the patient that your visual recovery will be as before, like after doing a posterior yak capsulotomy, then I think so, as Dr. Piyush said, OCT has a major role to play, especially.
Another thing, sir, most of the times we see that there are glaucoma patients in our clinic post cataract surgery status with PCO and they are on prostaglandin inhibitors. Do you think a need for a yak capsulotomy is a prerequisite to stop the prostaglandin inhibitors or change it, or maybe call the patient in a later date after changing the anti-glaucoma? Do you think it is required, sir?
In my practice, I haven't stopped prostaglandin inhibitor. I've just let it continue. Paresh, sir, anything to add on this?
Yeah, I think so. I'm absolutely agree that we don't discontinue the prostaglandins actually.
So you're not audible, Paresh.
Yeah, very. So actually, we also see that the cystoid macular edema can develop, but we usually don't stop prostaglandins in all these cases normally.
Dr. Kruthika, one question for you. After the yak capsulotomy, generally, what medications you advise and what is the dictum for that? Like, I've seen people advising non-steroidals, I've seen people advising steroids, anti-glaucoma. What is your take on this?
Ma'am, yeah, what I've gone through is even before starting capsulotomy, we should put a drop of anti-glaucoma medications prior to the procedure. That is 1 hour prior to the procedure. After which we should usually give anti-glaucoma medications. That is that up to almost up to all the surgeons they usually give. And coming to steroids or anti-inflammatory drugs, few of them prefer to give steroids and few of them prefer to give anti-inflammatory drugs. So I think either of them should do. That depends on, again, the energy used or the thickness of posterior capsular opacification, rise of IOP expected and all. So, and apart from that, we should also give nipafinac or soma, nipafinac, bromfenac, or anything as such.
Dr. Paresh sir, what is your take on this? What are your post-YAG medications that you usually provide to your patients?
Yeah, mostly all the cases of this yak capsulotomy, I usually put this anti-glaucoma medication before, and then after I give 10 days to the patient steroids along with the anti-glaucoma medications. Mostly, if patient is having no problem with the beta blockers, then I normally give a timolol, 0.5 percentage 2 times a day for 10 days, and steroids maybe some dexamethasone preparation, or sometimes if I feel, then I give a prednisolone also for 10 days. So for week to 10 days, patient puts all these drops, and again that patient come back to me for a final refraction, because sometimes there will be a difference in the refraction because of the this posterior capsular opacification, and you cannot judge it well. So when the patient is asking for a spectacles, then at the end of 10 days, that patient has to be corrected for that refractive power. Dr.
Yes.
Piyush? Anything special, Dr. Piyush?
Nothing. So even I add on a timolol, and I usually go in for a prednisolone acetate or loteprednol. I usually don't add any like nepafinac or anything. But if at all I have a feeling like if patient is diabetic, I add on a nepafinac for a month.
Okay. Okay.
Sir, I had a question. Like in case of posterior capsulotomy in pediatric cataracts, uh, is it necessary to do anterior vitrectomy in all cases, or we usually avoid doing an anterior vitrectomy after an age group of 5 years? Like some theoretical literature says, like till 5 years we should go for an anterior vitrectomy. Post that, we can avoid doing an anterior vitrectomy. It can lead to like developmental changes in the eye, like lengthening of the eye and all is usually hampered.
I think so. Literature also says, Kruthika will be agreeing with me, that in less than 2 years of age, I think so, anti-vitrectomy, usually they don't perform actually in less than 2 years. Maybe. But I don't have a much experience of a pediatric cataract surgery. So usually, I think so, as you say, that anti-vitrectomy is normally not done in less than 5 years of age group of patient. That's what I have actually heard with all pediatric surgeon with me. So they do normally only this capsulotomy, not an antivitrectomy. Dr. Kruthika, you have any literature on that?
Sir, literature, what I have searched for regarding anterior vitrectomy in case of, along with posterior capsulotomy is again, for less than 5 years, it is better to do anterior vitrectomy plus posterior capsulotomy, definitely. In age, if it is 5 to 8 years, it is left to doctor's choice. Some of them prefer to do posterior capsulotomy alone, and some want to do anterior vitrectomy as well to prevent the scaffold for development of PCO. And in case of more than 8 years, they definitely don't do anterior vitrectomy. They do posterior capsulotomy alone, either or by primary or post cataract surgery by YAG cap route.
I just want to ask you, what is the percentage of re-YAG in your practice, or Dr. Piyush also in your practice? How many patients require re-YAG or re-posterior YAG capsulotomy?
Like after YAG capsulotomy, I've done a re-YAG formation of an epithelium, or like growing of epithelial cells over the anterior hyaloid face.
No, sometimes the opening, if it has been made very small, then there will be
Okay.
again formation of these cells, and they again hamper the visual recovery. So I think so. Sometimes they do need a posterior YAG capsulotomy.
Quite less in my practice. Once I have done like a patient had turned up and she has already got a yak capsulotomy done few years back, and again I was seeing some anterior hyaloid phase was quite hazy. In that case, I've done a re-yak, not in my previously done cases yet.
Right.
Sir, I would like to say here that it is very, very rare that we have to do a re-yak because most of the time the opening made is at least 4 millimeters and centered around the pupil. It's only like even I have seen in very rare cases where the opening is too small. Sometimes a hesitant surgeon, in order to not cause much energy delivery to the posterior pole, or maybe in their own hesitation, they do a very small central opening. Even in multifocals, I have seen that post multifocal PCO also, people they just restrict themselves to the central part of the lens.
Very
So
true.
in those cases, I have noticed that the patient still complains of hazy vision, especially when they're reading. Because the near vision, when they're trying to focus at near, it causes a little bit of
Problem.
disturbance in their vision. So what I've noticed is unless it is very small, less than 3 millimeters and very, very centrally located, it usually doesn't require gag. Mostly nowadays, what I see people do cruciate type of pattern where the central and the inferior part is almost clear.
Right. Right. Okay.
Any questions, Kanika, on YouTube?
First, I want to ask you one thing. Do anyone has an experience of removing cells which are on the anterior part of IUL, anterior surface of IUL? Like there are, you can see in that these all cases, sometimes in a very complicated cases of a cataract surgery, there will be a dispersion of this cortex material or these cells, and these cells they get with pigmentation deposited on the anterior surface of IOL. And sometimes if you if you remove also posterior capsule, then also there will be some haziness in the vision that patient may complain. And I think so. Anyone has experience to remove it?
Yes, sir. In uveitic cases, like in long-standing uveitic cases, we usually see some pigments coming up over the anterior surface of the IOL. We have used YAG laser focused over those pigments and on a very low energy in anterior mode, and we have done and removed those pigments.
Right, right. So I think so. That is also that can be also done. So that lens part is absolutely clear. Thank you. Thank you. Right.
So there are no questions on the YouTube channel. I think we can call it a day. Thank you so much, Paresh sir, for giving us your time. Thank you, Piyush sir, for moderating the session. And thank you, Dr. Kruthika. That was a very informative and detailed talk on this topic. Let's call it a day then.
Thank you. Thank you, Dr. Kanika. And
Thank you, Dr. Kanika. Thank you, Paresh sir. Kritika, very nice presentation.
Thank
very
you.
Thank
detailed
you.
presentation, Dr. Kruthika. Very
The
nice.
opportunity.
Yeah, you explained it very well.
Thank you, sir.
Thank you.
Thank you, sir.